this training video on trauma-focused cognitive behavioral therapy for children and adolescents. I'm Mark Brennan, your host, and I'm Project Director for Continuing Education Television at the Missouri Institute of Mental Health in St. Louis, Missouri. And with me today is Dr. Matt Kliethermes, who is a clinical psychologist who received his degree in psychology from St. Louis University in July of 2003. He has extensive experience providing psychological services to children with specific focus on assessment and treatment of symptoms of post-traumatic stress. In addition, he has experience that extends into the area of child trauma, including assessment and treatment of sexually abused children at the Children's Advocacy Services of Greater St. Louis, and in a year-long rotation at La Rabida Children's Hospital in Chicago, Illinois, where he provided psychological services to survivors of child maltreatment and trauma. Welcome, Matt. Thanks for coming with us today.
Nice to be here.
As an expert in dealing with trauma and, I guess, cognitive behavioral therapy, one of the first questions that I could ask that I think the audience would be interested in is, what are traumatic events and how do they impact children?
Okay. Basically, a traumatic event is any situation where a person either experiences or witnesses a threat to their life, or physical injury, or just a threat to their physical integrity. And really, it's a situation that involves someone being under or experiencing intense distress, a lot of fear, a lot of with children, it could be really disorganized behavior or just sort of uncontrolled behavior.
So for children, generally, what kinds of situations would result in trauma?
Okay. Well, there's really a wide variety of situations that a kid could be in that could result in trauma. Some of the more common ones that I have experience with are things like sexual abuse, physical abuse, domestic violence is a pretty common one. And then also things like homicide, witnessing a homicide, witnessing or experiencing a loved one committing suicide, and also things like community violence and accidents, serious accidents like automobile accidents.
So any situation that a child might be in that would result in trauma is the kind of situation that you would be focusing your treatment on.
Exactly.
So for the audience, can you talk to us a little bit about what cognitive behavioral therapy is and specifically as it relates to trauma focus?
Okay. Basically, trauma-focused cognitive behavioral therapy is it's a treatment model that combines behavioral treatment techniques with cognitive techniques with a little bit of a unique twist in that it's focused strictly on the trauma that the child experienced. And really some of the key component or the key goal of trauma-focused therapy is to really address the fears and the distress that the child experiences related to that trauma, and to try to break the association between the distress they feel and the memories that they have of that. Because the problem with trauma is that it's not a one-time event. Once it happens, we're stuck with the memories of it. I'm sure anybody watching this will have very vivid memories of the World Trade Center and the plane hitting the World Trade Center. And for a kid who's experienced a trauma, it's the same thing. Those memories just tend to repeat themselves over and over again. And the distress that they experienced right at that time is repeated as well.
Okay.
So really the goal of trauma-focused therapy is to break that association.
And the theoretical model then would go along with that?
The theoretical model is basically, it's based on learning theory and cognitive behavioral, or cognitive theory. The idea is that the symptoms of post-traumatic stress are caused and maintained by both behavioral impacts and also cognitive factors as well.
Okay.
For example, both with regard to learning theory, both classical conditioning and operant conditioning are involved. If you think back to Pavlov's experiments, you had a dog who was exposed to the bell and the meat powder at the same time and started to salivate. The same thing sort of happens with traumatic events in that the child associates the trauma with certain things that are around them at that time. And so anytime they come into contact with those reminders down the road, they experience distress. Then also cognitive factors play a role too. One of the primary ways that happens is that anytime you experience an event, you process it. You think about it, you look at the different aspects of it, and then you store it in memory. The problem with trauma is that we don't want to do that. We want to avoid doing that so we don't experience the distress that goes with it. The problem with that is that we never really fully process it, so it just sort of stays in our towards the upper level of our thinking. It's sort of always on our mind because we can never totally put it away. So one part of treatment is that we want to help them complete that processing so they can sort of put it back in long-term memory and not have it be at the forefront of their thoughts all the time.
I got to ask you, a lot of times when there are things that are discomforting to me, and like you were saying, I don't want to necessarily think about it because it causes me discomfort, how would you be able to get me to do that? Because I imagine most of us really would resist that a lot.
And really, that is one of the big keys to trauma-focused therapy is you have to get that buy-in. And it's not always easy to get. One of the ways that I like to handle it is I use a lot of analogies and metaphors. And one of my favorite ones for this is the idea of when you get a splinter. When you get a splinter, it's in your finger. You don't want to pull it out. It hurts to pull it out. The problem is if you don't pull it out, you run the risk of it getting infected or getting deeper in, so it's going to hurt more. So really the best thing to do is, even though it's initially kind of uncomfortable, is just to get in there and dig it out so then it can heal. And that's sort of the rationale I use to explain it. It's that, yeah, it's not at all comfortable to talk about this, but if we do it now, it's going to help the chances of healing.
Oh, okay. So when you start talking about interventions like that, it reminds me of the importance of understanding treatment objectives. So could you talk to us about the treatment objectives for this particular approach?
Sure. The basic treatment objective, which I already kind of mentioned, is that you want to break the associations that the child has between the memories of the trauma and the distress that they experienced at that time. Other goals is that you want to correct any misthoughts that they have, any cognitive distortions that they have about the trauma. And there's a variety of distortions that a kid could have. They may blame themselves for some aspect of it. And obviously, if they're blaming themselves, that's going to result in maybe depressive symptoms or just distress in general. So really, that's another important goal. And the other thing is that you want to provide them with new ways of coping, new ways of dealing with the distress that they feel. And this is also where it's important to involve the parents, because they're also they probably could use some new ways of coping themselves because they're experiencing a lot of the distress that the kid is experiencing. But also they're going to serve as a great model for the kid as well. So it's really helpful to have the parent there to model it for them too.
Well, I've got a question I want to follow up on that. What if the parent is the cause of the trauma? Do you still involve them in?
Typically with this, you do not involve an offending parent.
Okay.
And actually one of the books that a lot of this is based on, the title of it is Cognitive Behavioral Therapy for Sexually Abused Children and Their Non-Offending Parents. So really you want to involve a caregiver that's was not involved in the trauma, at least wasn't the perpetrator of the trauma.
Well, in deciding to use this approach with children, how do you determine its appropriateness or inappropriateness?
Okay. In terms of its appropriateness, there are a few factors to consider. Really, any child under age 3 is probably not real appropriate for, just that they really don't have the cognitive abilities necessary to do some of the work that's involved. If a child is experiencing psychotic symptoms, it's not really a good idea to utilize this, just because there's really to be honest, there's a certain amount of stress that comes with talking about these events. And typically that stress combined with psychotic symptoms can worsen the psychotic symptoms. Also, if there's any sort of, for older kids, teenagers, if there's substance abuse or substance dependence, it's not really a good idea to utilize this. And also if there's any sort of suicidal or self-harm, serious suicidal intent or self-harm. Again, you don't want to distress them more at that point. So it's good to have them, that risk decrease before you start this treatment.
Can you talk to us about the components of trauma-focused cognitive behavioral
Sure.
therapy?
One of the first components is education. You want to educate the child and the parent about what trauma is, what are normal responses to trauma, and also just about treatment. What are the treatment goals, what are the strategies, what are the techniques, just to prepare them for that. A second component is called stress inoculation techniques. And really what you're doing there is you're giving them coping skills to deal with distress. This focuses a lot on relaxation techniques like deep breathing. There are two more components. The next two are gradual exposure and affective and cognitive processing. Then some of the other components, there's really basically two more. Safety skills is a big one. You want to help them learn to avoid similar situations in the future. Of course, this is a little bit of a tricky prospect because you don't want to give them the idea that you're blaming them for what happened either. So here another analogies are another good thing to use here, and I'll often use the idea of a tornado drill. You're teaching them sort of skills that they can use to protect themselves in a situation that's really sort of out of their control. Just like you wouldn't blame a kid for a tornado, you're not trying to blame them for how they responded then either. And finally, the last thing is really the parent involvement, and that takes two primary forms. The first is that you really sort of involve them in all of the treatment components that you're doing with the kid, sort of in a parallel format. You involve them in the gradual exposure, you involve them in the stress inoculation, primarily just because you want them to know what's going on so they can then in turn work with the kid on these same things when they're at home. Then the second way that you involve them is kids that experience trauma also frequently have behavioral problems. I always kind of liken it to, you can have a kid who really didn't have behavioral problems, but after a trauma, it really just sort of shakes up his world. Kind of like if you talk about honeybees. Honeybees are normally pretty docile, they're not going to attack people, but if you run up and shake up their hive, they're going to come out and want to sting you. And really it's the same way for kids. They've experienced something that's really just shaken up their entire world. And so some anger and some irritability are kind of expected. So you also have to work with parents on ways of dealing with those behaviors as well.
So you not only, I was going to ask you, not only involving yourself in therapy with the child, but you're also instructing the parents and the child in some ways that they might be able to handle situations in the future.
And also, in some ways, you're almost doing therapy with the parents as well, because either they did experience the trauma, or it was traumatic just to know that their child did. And so they've got a fair amount of distress and trauma symptoms as well, frequently. So there's also some co-work that you're doing with them along at the same time.
A few minutes ago you mentioned gradual exposure. Do you want to talk to us about that?
This is really, gradual exposure is probably the most unique component of trauma-focused therapy. And what it involves is this is where, when I was talking about helping the child process the trauma, this is really part of that. And what you're doing is you're creating a narrative, more or less. You're helping them process their story about what happened. So you really kind of start from the beginning and just go through with them, helping them talk about what they experienced, what they remember, and then also what they were thinking about when it happened and what they were feeling when it happened. So basically you're creating the story of the trauma. And the reason this is helpful is by doing this, they learn that they can face those memories in safety. It's not dangerous to face them. They do it. They come out of it okay. And that's part of how you break that association between the trauma memories and the distress that they experience.
Do you do that in graphic form? Like, for instance, would you have a kid write the story? Or
you can honestly do it in just about any modality you can think of. I've done puppet shows, I've done drawings with kids, a storybook, and also you can just do it orally as well. Some kids prefer to do it that way.
Sure. You also mentioned cognitive and affective processing. Can you talk to us about that?
And this really it goes hand in hand with gradual exposure, in that with the cognitive and affective processing, you're really trying to get a sense of what they felt and what they were thinking about during the trauma, and really trying to help the child understand what they were thinking about and what they were feeling. So a lot of this involves talking a lot about what they were thinking about when it happened, what they were thinking about after it happened, and really just helping them get an understanding for themselves of what actually happened. Mm-hmm. And another important thing that you're doing here is you're looking for distortions. Mm-hmm. You're looking for things where they're doing some inaccurate thinking. Mm-hmm. And this also involves working with them to correct that thinking. So, for instance, if a child's blaming themselves for, let's say it's a case of domestic violence, and they're blaming themselves for not doing more to stop dad from hurting mom, you can do some work on talking about, well, just what can a 5-year-old kid do to stop a 30-year-old man from hurting someone?
Sure.
And just really pointing out that there are realistic limitations to what they could have done, mm-hmm. and that they can't be blamed for not exceeding those limitations. Mm-hmm. So really just pointing out the areas of distortion and trying to help them develop more realistic, healthy thoughts and beliefs.
What's an average time frame that all of this occurs in?
Yeah. Surprisingly, it sounds like a lot, but it's a fairly short-term treatment. I would say if I had to give a range, an average range, probably about 10 to 20 sessions.
Oh, that's not bad.
Is what it would take, weekly sessions.
Sure. And that would also involve the parents?
Yes. Usually what I will do is I'll split each session in half, do about 30 minutes. For the first half of treatment, I'll do about 30 minutes with the parent, then 30 minutes with the child. And then for the last half, I may do that, but then also I may have joint sessions more frequently. Okay. Because one of the important aspects of this is I like to have the child share their narrative, their trauma narrative, with their parent, mm-hmm. Which is a really effective component of treatment for both the parent and the child.
Sure, I imagine it's pretty cathartic.
Very cathartic. And also it clears up a lot of distortions that both the parent and the child have about how each party is dealing with the trauma. Mm-hmm. Frequently, kids expect the parents not to be able to handle listening to it, or maybe not taking it the way they want them to take it. And parents are also worried about, whether the kids can handle it, whether maybe we should just not talk about it. Sure. And so really by allowing them to see that both parties can deal with this, it's pretty effective in that way.
Well, let's talk a little bit about empirical evidence that mm-hmm. supports this approach.
In terms of trauma-focused treatment for children, really it's by far and away the most researched form of treatment, mm-hmm. and it's the best supported form of treatment. There have been quite a few studies done primarily with sexually abused children that have compared trauma-focused cognitive behavioral therapy with just non-directive supportive therapy. Mm-hmm. And pretty well across the board, they've shown that the trauma-focused cognitive behavioral therapy, they'll see more significant improvements in post-traumatic stress symptoms, depressive symptoms, a decrease in behavioral problems as compared to just more supportive therapy.
Mm-hmm. For folks out in the audience who might be viewing this, what would you suggest, where would you suggest they go to get more information on cognitive therapy?
In general, there are two, probably one of the best books, which I mentioned earlier, is Cognitive Behavioral Therapy for Sexually Abused Children and Their Non-Offending Parents, which is by Esther Deblinger and Ann Heflin, mm-hmm. 1996. Okay. And it's really lays out exactly all the things I've talked about. And just in general, in terms of information on trauma and treatment, there's a really good source on the internet. It's the website for the National Child Traumatic Stress Network, mm-hmm. and the address is nctsnet.org.
Thank you. Thanks. Thanks, Matt, for being with us. Your topic, trauma-focused cognitive behavioral therapy with children and adolescents, has been a very interesting and timely topic considering the events in today's world. I encourage everybody in the audience to research cognitive behavioral therapy, especially as it relates to children and adolescents. And I also encourage you to look at the key concepts, to examine the points of application prior to taking your tests, and you won't have any problem. Good health and good luck.